Good morning. Welcome you all for another edition of Online Anesthesia postgraduate teaching program on Zoom platform, sponsored by Acrola and hosted by A1 Logistics. Today we have three interesting topics. The first topic is pulmonary function test and the preparation of the patient for lung resection surgery by Dr. Guru Santhiya. The second topic is from Dr.Kala Eswaran. He is a senior consultant from Mumbai. She is going to talk about the landmark guided Fascia Iliaca Compartment Block. Postgraduates, I want to emphasize one thing. Whatever you may be well versed with ultrasound guided nerve blocks, but you have to learn about the landmark guided nerve block also. Because when you go for a practice, all the hospitals will not have a ultrasound. So you may be forced to give nerve blocks without ultrasound. So you must be well versed with the landmark guided nerve block also. That's why we have included landmark guided nerve block in this session. And the third speaker, that is Professor Sathish Kumar from CMC Vellore. He is going to talk about the lung isolation methods, and he is having very interesting videos of DLT and bronchial blockers. So don't miss it. So with its short introduction, I hand over the session to Dr. Santhiya to introduce the speakers and carry out the further session. Thank you.
Thank you, sir. We welcome you all for our online anesthesia program. The first topic will be on pulmonary function test and preoperative assessment for lung resection surgery. We invite Dr. Guru Santhiya ma'am to enlighten us on this topic. She is a consultant anesthesiologist at Kumaran Medical Center, Coimbatore. She is a voracious reader and a very humble person. Over to you, Dr. Guru Santhiya.
Thank you, Dr. Santhiya. Okay. Good morning, all. I'm Dr. Guru Santhiya, and I will be discussing about pulmonary function test and preoperative assessment for lung resection surgeries. As pulmonary function test, we all have known it is a battery of studies or maneuvers which is performed using a standardized equipment to assess the lung function. In order to assess the lung function, it involves three main parameters. One is lung mechanics, which involves measuring the lung volumes and capacities. And the other one is gas exchange, which is primarily a parenchymal function. And third is the interaction between the heart and the lungs, between the right heart and left heart and the bilateral lungs, which involves the cardiopulmonary interaction. The indications for pulmonary function test includes diagnostic as well as prognostic. In diagnostic, we are mainly using it to evaluate symptoms, especially cough or dyspnea, when the patient has a chronic dyspnea, to evaluate if the patient has got any COPD or so. And screening of at-risk patients, smokers, or those who work in a cotton mill or exposed to the asbestos, so asbestosis, sarcoidosis, to rule out those, we are using for screening the at-risk patients. And preoperative risk stratification, as in the patients undergoing major abdominal surgery or cardiac surgery and thoracic surgery. And to monitor the drug toxicity, especially bleomycin and the cytotoxic agents. To measure the drug toxicity, we are using the pulmonary function test, because the results in the pulmonary function test will become evident even before the patient presents to us with the clinical features. In order to make a prognostic assessment, what was the PFT before and what is the PFT now? How has the patient progressed? Has the patient deteriorated or improved with the treatment? How is the response to treatment? Whether the PFT is reversible with bronchodilators or it is not reversible, what are the treatment goals can be planned with the pulmonary function test? What are the contraindications for it? Unstable angina, any recent angina within 1 month, patients having thoracic aortic aneurysm or cerebral aneurysm, all those patients are contraindicated to undergo a pulmonary function test. Any patient who has got an active hemoptysis, who has undergone a recent ocular surgery less than 1 month, and who has a pneumothorax are contraindicated to undergo a pulmonary function test. Pulmonary function test basically includes bedside pulmonary function test, which measures the vital capacity and the dynamic test. Next one is the one which is going to measure the lung mechanics, which is the dynamic and static lung volumes. Then comes the parenchymal function, which involves the gas exchange and the diffusion capacity. Then is the cardiopulmonary interaction, which involves 6-minute walk test or shuttle walk test, cardiopulmonary exercise testing, and the measurement of oxygen consumption. The one which is done least is the split lung function test. With all these parameters, we are going to form the free-legged tool for the preoperative assessment and predict the postoperative outcomes in the lung resection surgery patients. Bedside pulmonary function test involves measurements of vital capacity, which includes subarachnoid bed holding test and single breath count test, measurement of vital capacity and dynamic function, which includes Snyder's match blowing test, forced expiratory time, Greene and Berowitz cough test, Debenhams whistle, a Wright's peak expiratory flow meters, and the others include arterial blood gas analysis, routine Polysoxymetry, which is available at the bedside. It gives us the idea about the room air saturation and the pulse rate, and the respiratory rate, if at all the respiratory rate is high. Chronically, if the patient's respiratory rate is high, then the patient may have a respiratory fatigue. And if you're trying to wean the patient off the ventilator, then the patient may have a desaturation and weaning failure. So first coming on to subarachnoid breath holding test. This is the first bedside pulmonary function test which we are seeing. You ask the patient to take a deep breath and then hold. If they can hold for 25 seconds, then it means a normal cardiopulmonary reserve. If it is only for 15 to 20 seconds, it's a limited cardiopulmonary reserve. And it is less than 15 seconds, it's a poor reserve. In this, if the patient is able to hold for 20 to 25 seconds, then the vital capacity is somewhere around 3000 ml. So we can remember it like this: 20, 25, and 30. The same goes 15 to 20 seconds, then the vital capacity is 2500 ml. So, and so on. Next is the single breath count test. So you take a deep breath and then count 1, 2, 3, 4, like 1, 2, 3, 4. So if I'm able to count more than 20, then it means a good cardiopulmonary reserve. Then comes, this is a test which assesses the vital capacity, maximum breathing capacity, as well as the dynamic function of the lung. It happens in a quiet room. The ability to test, the testing is to blow a match at 6 inches distance or 15 centimeters with the chin rested or supported, with no pursing of lips and mouth wide open. There should be no air movement in the room. It is obvious, isn't it? If there is air in the room, then the air will blow it and the patient is not blowing it. So there should be no air movement in the room, and mouth and the match should be at the same level. So initially what was there was, if you are able to blow it at 6 inches, then the maximum breathing capacity is somewhere more than 60 liters per minute, and FVV1 is more than 1.6 liters per minute. Then Osland modified it into this and gave us 3 values. If the patient is able to blow at 3 inches, it means the maximum breathing capacity is more than 40 liters per minute. And if the patient is able to blow more than 9 inches, it is more than 150 liters per minute. Then Greene and Berowitz cough test. You ask the patient to take a deep breath and then cough. In the event of COVID, I don't think any one of us is going to do it, but then it is there in the literature. So the ability of the patient is to cough, the strength of the cough, the effectiveness of the cough, and whether the cough is productive or non-productive. If it is productive, then it means that the patient has got a pulmonary congestion or a pulmonary infection, and your patient is going to have an increased risk of postoperative pulmonary complication. If the cough is inadequate, it means the FEV1 is less than 15 ml per kg, forced vital capacity is less than 20 ml per kg, and the PEFR is less than 200 liters per minute. Then all these predisposes the patient to have an increased postoperative pulmonary complication. Then forced expiratory time. What we ask the patient to do is take a deep breath and then hold the breath. Then ask the patient to exhale maximally. When they exhale, you have a step over the trachea and measure over how many seconds the patient is actually exhaling. So if its normal value is 3 to 5 seconds, and if the patient is not able to exhale, able to exhale more than 6 seconds, it means it's an obstructive disorder. And if the breath stops below 3 seconds, then it means it's a restrictive disorder. Then comes the right peak expiratory flow meter and Debenhams whistle. This assesses the peak expiratory flow rate. The peak expiratory flow rate normal value is 450 to 700 liters per minute in male, and in female it is 350 to 500 liters per minute. Anywhere less than 200 liters per minute predisposes the patient to have an ineffective cough and predicts the patient for POPC. So this is the right peak expiratory flow meter, and this is Debenhams whistle. You're going to blow into the Debenhams whistle until there is no whistle sound heard. The last value at which the whistle sound heard is the peak expiratory flow rate. So as of now, we have seen only the bedside pulmonary test, which are assessment for vital capacity and dynamic function, and others like ABG, pulsoximetry, and respiratory rate. Now we have moved on to lung mechanics. Lung mechanics involves static and dynamic maneuvers. This is measured by a spirometry, which is introduced by John Hutchinson into practice. It involves measuring the static lung volumes and capacities and applying dynamic maneuvers. In static lung volumes and capacities, to measure the spirometry, there is an acceptability criteria and a reproducibility criteria. So to do a spirometry, there should be no artifact, there should be no leak, there should be no early glottic closure, or the patient should not cough in between the spirometry assessment. And in exhalation, there should be at least 6 seconds in the volume time graph with the plateau at least for about 1 second. What is the reproducibility criteria is you ask the patient to repeat a spirometry over 3 to 4 times. You measure FVC at the first time, second time, and third time. Take 2 largest FVCs. If the difference between 2 largest FVCs is just 200 ml, then it is an acceptable spirometry. Same goes with the FEV1. Take 2 largest FEV1. If the difference is more than 200 ml, then the spirometry is not acceptable. You ask the patient to do a maximum effort of 8 efforts. After 8 efforts, the patient may become fatigued to do a deep inspiration and expiration maneuver, and the patient may end with the sub-maximal effort as you see in this pulmonary tracing. So you do not ask the patient to do it more than 8 times. If the reproducibility criteria is not met, you give some time and repeat the pulmonary function test until you are able to get a reproducible figure like this. See, the 2 FPV1s are very close to each other, not more than 200 ml difference. This is an acceptable effort. This, the patient has made only a submaximal effort from the normal one, and hence this PFT is not an acceptable PFT. In this spirometry spirogram, the patient has tried to cough in between, and hence it is not acceptable. The same goes for all these parameters. These spirometries are not acceptable. This is a volume time graph in which it shows this is a good effort. This is time in the x-axis and volume in the y-axis. You see 0, 1, 2, 3, 4, and this is the 6th second. The patient has expired fullest to the 6th second and was able to hold it. So this is a good effort. In this, the patient has tried to do this. That's all. The expiration has terminated very prematurely at the second or so. So there is a premature termination or glottic closure. So you do not accept this volume time graph into the spirometry. And the patient has tried to cough in between. This also you do not accept because it has got an artifact. So this is the only acceptable PFT here, and this is the only acceptable PFT here. Coming on to the static volumes, which is the lung volumes and capacities. There are 4 volumes and 5 capacities. The volumes include tidal volume, inspiratory reserve volume, expiratory reserve volume, residual volume. Closing volume is somewhere new, and I'll discuss it later. And the capacities include inspiratory capacity, expiratory capacity, vital capacity, functional residual capacity, and total lung capacity. In this, what is tidal volume is the normal inspiration and expiration. How much amount of air you are able to take in and breathe out during the normal tidal respiration constitutes the tidal volume. On top of the tidal volume, how much amount of air you are able to maximally inhale is inspiratory reserve volume. Following the deep inspiration, how much amount of air you are able to exhale following the tidal volume is the expiratory reserve volume. Then comes the residual volume. How much amount of air is remaining in the lungs after a deep expiration following a deep inspiration is the residual volume. As you can see in the graph, this cannot be measured by a spirometry. Coming on to capacities, first is the inspiratory capacity. Inspiratory capacity is nothing but tidal volume plus inspiratory reserve volume. Then comes the expiratory capacity, that is tidal volume plus expiratory reserve volume. Then comes the functional residual capacity, which is the expiratory reserve volume plus the residual volume. As you can see, this total thing is the functional residual capacity. This functional residual capacity, as you can see, it is the remaining volume of air in the lungs following a normal tidal respiration. So this forms the basis for, as we have read it in the earlier lecture from Dr. Edward Johnson, this forms the basis for the oxygen source and it is the buffer, and the pulmonary vascular resistance is very low at the volume of FRC. This prevents the lung from getting atelectatic. As you can see, the lung is quite open during the normal tidal respiration. A balloon which is already inflated is easy to inflate. So from FRC, it is again easy to inflate, and this brings down the PVR as well. This is the oxygen store which we are trying to pre-oxygenate and denitrogenase and get the patient to have a prolonged apneic time without desaturation, and this is FRC. What is vital capacity is the total lung capacity minus the residual capacity. This vital capacity is important because both vital capacity and FRC has got its predominance in anesthesia because these have a decrease or they have the propensity to decrease when the patient is anesthetized or when the patient is put in a specific position, with vital capacity decreasing up to 14% in lithotomy. In patients who are anesthetized, this FRC is going to decrease further if the patient is going to be placed supine, and it is going to be decreasing further when you're anesthetizing the patient and paralyzing the patient. So what are the normal values for these volumes and capacities? The tidal volume, it is 6 to 8 ml per kg. The inspiratory reserve volume is close to 2 liters to 3 liters. Expiratory reserve volume is 1.5 to 1.8 liters. And the residual volume is 20 to 25 ml per kg. Then the FRC is 30 to 35 ml per kg. Vital capacity is 60 to 70 ml per kg. And total lung capacity is somewhere around 6 liters. So what are the volumes which are not measured by spirometry? It is the residual volume. Hence, whatever which includes the residual volume cannot be measured by spirometry. So what do we use to measure? It is a nitrogen washout technique, helium dilution technique, and body plethysmography. In case of closing volume and closing capacity, it is a single breath nitrogen exhalation test. So coming on to residual volume measurement, how do we measure is by 3 methods. Nitrogen washout, you ask the patient to inhale 100% oxygen and the exhaled volume is measured for the nitrogen concentration, and then it helps to measure the residual volume. In helium dilution method, the patient breathes in and breathes out of a reservoir which contains a known value of helium over 7 to 10 breaths. So the concentration of helium is actually noted, and then it measures the dilution across the respiratory pathways, and it gives only the residual volume which has a communicating one in the sense which is participating in the gas exchange. Then comes the body plethysmography, in which the patient is placed in a body box known where the pressure and the volume is known. Here, the Boyle's law is used, where at a constant temperature, the volume is inversely proportional to the pressure drop. So, provided the volumes is known, the pressure drop is known, we can calculate the volume of the residual volume which is there. So, the body plethysmography is the only one which calculates both the communicating and the non-communicating gas volumes. So coming on to closing volume and closing capacity, though it doesn't come under our topic proper, but then it is important to discuss here. It is because closing volume is the volume at which the airways close. As you can see in the graph, this is tidal volume, this is inspiratory reserve volume, this is the expiratory reserve volume which is there, and this is the residual volume which is remaining in the lungs. Then this is the place where the airway closure begins. In a normal expiration, during quiet expiration, what happens is the lung elastic recoil tries to wash out of the lungs of the air. At some point, there is a positive pressure across the airways where the pleural pressure tends to overcome the airway pressure. There reaches a point where it is called an equal pressure point, where there is no longer airflow across the airways because the pleural pressure is exceeding the airway pressure. Then the airways actually tend to close, and that volume is called as a closing volume. So when there is a cessation of expiratory airflow, and that volume at which the lung volume at which that occurs is the closing volume. As you can see in this graph, the FRC is actually above the closing volume, above the closing capacity. This is responsible for maintaining the normal oxygen saturation, and there is no physiological desaturation because of this. But when the age advances, this changes in the respiratory system happens. And as you can see, this is a graph showing age in years in the x-axis and total lung capacity percentage in the y-axis. As you can see, this is a residual volume, this is the closing volume, and this is the FRC in supine. This dotted line is the FRC in supine. As you can see, when the patient approaches 40 years or so, this FRC is approaching, the closing capacity is approaching the FRC, which means the FRC falls below the closing capacity, closing volume, if the age is more than 44 years. Then there is going to be a physiological shunt and desaturation, which is going to occur. So in patients when the patient is becoming upright, this is the same graph, age in years and the total lung capacity in percentages. This is a residual volume. This is the closing volume. As you can see, the straight line is the FRC in upright position. Okay, so close to 66 years or so, the FRC is, the closing volume is approaching the FRC. So even when the patient is sitting upright, the FRC may be less than the closing volume when the age advances, which may lead to a physiological desaturation. So this is very important to know. So hence, to maintain the FRC is actually better at a 30-degree head-up angle. That is why after you extubate, you put a head-up position so that it is above the closing volume and not below the closing volume. As of now, we have seen only bedside pulmonary test and the lung mechanics involving the static lung volumes and capacities. Now we are going to see the dynamic test. With the first one is the volume time loop. What is a volume time loop? You actually ask the patient to inhale maximally and then exhale to a forced vital capacity, which is shown here like this. So exhale over 6 seconds. That is normal, which I told for the criteria for doing a spirometry, right? So, or a PFT. So this time is the x-axis. This is in seconds, and this is the volume in liters in the y-axis. What we are going to do is measure the volume and the time. So this is a volume time loop. And if the patient is going to make a breathing during the expiration, then you actually cancel this and do this again, and then get a graph clearly as this to get a proper PFT done. So what is forced vital capacity? It is a volume of air that is exhaled after a maximal inspiration. It actually reflects the flow resistive properties of the airways. The normal is somewhere close to 80 to 120% of predicted. All the spirometric values are actually predicted ones from the height, weight, ethnicity, and race. They are usually expressed in percentages like 80 to 120% predicted. So 80 to 120% predicted is normal, 70 to 79% is mild reduction, 50 to 69% is moderate reduction, and less than 50 is severe reduction. So what is FVV1? It is the forced expiratory volume at the first second. So here, as you can see in this graph, this is time in seconds. The patient has exhaled over more than 6 seconds. So it is okay. And whatever the volume of air that is exhaled in the first second forms the FEV1. This is the time in x-axis. So first second, this is the corresponding value. So over to 3.2 liters is what the patient has exhaled in the first second. FVC is close to 4 to 4.5 liters and 80% of it forms the 3 liters. So 80% of the FVC is exhaled in the first second, and this is normal graph. So if at all there was any obstruction, the FEV1 should have fallen here as in this graph. So it assesses the airway obstruction. Normal value is if it is more than 80% predicted, it is normal. If it is 60 to 80% predicted, it is a mild obstruction. 50 to 59%, it is a moderate obstruction, and less than 49% is severe obstruction. So this is a Tiffany's index, which is used to differentiate whether the lesion in the respiratory pathway is an obstructive one or a restrictive one. Normally, the value is more than 0.8. So FEV1 by FVC, the normal value is more than 0.8. The two very important lung disorder which we are worried about are obstructive and restrictive pathology. In obstructive pathology, how to differentiate this from other, with the PFT, how to differentiate between obstructive and restrictive pathology has been a nightmare for everybody. So in an obstructive pathology, in this volume time graph, as you can see, this is a normal graph and this is an obstructive pattern graph. What happens is there is a significant drop in case of an obstruction in the FEV1. So the numerator is kind of decreased in the obstructive pattern. As you can see, the FVC of normal and the FVC of obstruction is more or less equal to each other. So the FVC is near normal. Since the numerator is only decreased, the denominator is maintained, it actually leads to decrease in the FEV1 by FE ratio less than 0.7. In restrictive disorder, what happens is, this is a normal graph. There is a concomitant fall in FEV1 as well as FVC. Since numerator and denominator both are decreased, usually FEV1 by FVC is maintained, that is more than 0.7. In a restrictive disorder, all the lung volumes are decreased, say total lung capacity, residual volume, functional vital capacity, FEV1, all are reduced in case of a Tiffany's, restrictive pathology. Till now, what we have seen is the dynamic test, only the volume time parameter we have seen. Next volume time parameter is a maximum breathing capacity. It's a volume time parameter because the forced vital capacity into respiratory rate gives us the maximum voluntary ventilation. One cannot respire for over 1 minute with deep breath, exhale deeply, deep breath, exhale deeply. So it is done over 15 seconds and extrapolated over 1 minute. That makes common sense. So in males, it is 140 to 180 liters per minute, and females, it is 80 to 120 liters per minute. Next comes the dynamic test. In dynamic test, as of now, we have seen only the volume time loop. Now we are seeing the flow volume relationship. In flow volume relationship, we will be seeing about peak expiratory flow rate, maximum mid expiratory flow rate, which is the FEF 25% to 75%, and the flow volume loop assessment. This is the volume time loop which we have seen earlier. Time in seconds and volume in liters per minute. So this is the FEV1, which is the first second, which is 4. This is the loop of the flow volume loop, which we will be seeing it later. And in this graph, this is the FEV1. See, this maximal expiration which has occurred is the peak expiratory flow rate, and the decreasing part of the curve is the FEF 25%. This is the fraction expired 50%. This is the fraction expired 70%. Coming on to flow volume loop, as we have seen in the before graph, this is plotted as volume in liters in the x-axis and flow in the y-axis. So that forms the flow volume loop. So here, the inspiration forms the deflection in the lower part. This is the lower part and this forms the inspiration. And then the patient expires and that forms the expiratory part of the curve, which is above the x-axis. In the inspiratory part, inspiration is totally effort dependent. So it is totally effort dependent. And in the expiration part, this part of the graph until the peak expiratory flow rate is effort dependent. After this part of the graph, whatever effort you put in this part of the graph, this is going to be an effort independent part of the curve. Whatever amount of extra effort you put, you will be exhaling the same amount only, no amount extra. Okay, so this part of the curve is effort dependent and this is effort independent. So this is actually used in detecting a changes in the smaller airways. And coming on to measurement of peak expiratory flow rate and maximum mid expiratory flow rate, as we can see, this is the inspiratory part of the curve and this is the PEFR, which is the peak flow, and this forms the mid portion of the curve. Normally, the mid portion of the curve, this constitutes around 3 to 4 liters of the expiratory volume. This part of the curve is the effort independent curve. As you can see, this peak expiratory flow rate, when you make a maximal effort, this can increase. When you make a minimal effort, this is not going to go. See. So depending upon my effort, if I put a modest effort, my peak expiratory flow rate is going to increase. If I put a submaximal effort, again my peak expiratory flow rate is going to increase until the maximal effort. So the peak expiratory flow rate is effort dependent. This forms the pathway until this it is actually managed by the larger airways. Whereas this part of FV, F25% to 75% is actually managed by the smaller airways. So no amount of effort I put, there is going to be no change in the slope of the curve. If at all the effort has put some change in the curve, then the curve might have become like this. Then this curve might have become like this. The submaximal curve, if it was effort dependent, would have become like this. It doesn't happen because this is the effort independent part of the curve. So here the patient is maximally inhaling to total lung capacity. So in the x-axis, whatever it is at this junction is the total lung capacity, and whatever the patient is then exhaling maximally deep to the residual volume. So at this point, it is the residual volume. As you can see in this graph, this 2 liters is the residual volume. This 6 liters is the, here it's 6. So 6 liters is the total lung capacity. So severity assessment, as I told earlier, FEF 25 to 75%, it is effort independent. It is the earliest and the sensitive indicator of small airway changes. If it is more than 60%, it is predicted normal. 40 to 60 is mild obstruction. 20 to 40 is moderate obstruction, and less than 10 is severe obstruction. So this is one graph equivalent. As a postgraduate, I always wondered what I was going to do with this. So after reading for quite some time, I learned this is nothing more than understanding the subject. So here, this is a normal graph, which we have seen for so many times from now. You are actually inspiring from the residual volume to total lung capacity and then expiring to the residual volume. What happens in case of an obstruction? In case of an obstruction, as we have seen in the Tiffany's index, the FEV1 is reduced, but the FVC is okay. The total lung capacity also is going to be okay, but only the expiratory part is going to be affected. So as you can see in this graph, the inspiration is okay in case of an obstruction. In case of an early obstruction, what happens is the patient maximally exhales. In an early airway obstruction, when there should be an expiratory curve like this, it just goes because of an early airway closure because of obstruction. That is all. But if it is going to be a significant airway obstruction, then the FEV1 is going to drop. The peak expiratory flow rate must have been this also is going to drop. The peak expiratory flow rate has dropped, and there is a concaving and a scooping upward leading on to a dog-like appearance as it would appear in an emphysema. So there is reduced FEV1, reduced PEFR, but the total lung capacity and the residual volume is actually close to near normal in case of an airway obstruction. So then comes the restrictive pattern. In restrictive pattern, as I've said earlier, FEV1 is reduced, FVC is reduced, total lung capacity is reduced, residual volume is reduced, all of it are reduced. So as you can see, this is the normal graph. Here, the total lung capacity itself has decreased close to, say this is 3. So total lung capacity has reduced to 3 liters. Somewhere it was supposed to be 5 liters or 6 liters. It has reduced to 3 liters. And the maximal expiratory effort also is decreased. And again, the slope of the curve remains normal, but then all other values are decreased. So this is normal. This is an obstructive pattern. This is an early obstruction where there is just a concaving of the scooped or scooping up of the expiratory limb. In a severe airway obstruction, it happens wherein it gets a dog-like appearance because of the early airway closure as it would occur in an emphysema. Coming on to the next graph, where there is a fixed upper airway obstruction. Whatsoever the obstruction is there for both inspiration and expiration. So there is going to be a truncating appearance or flattening appearance of both inspiratory curve as well as the expiratory curve. As you can see in the fixed upper airway obstruction, there is a definitive obstruction. So it is there both for inspiration as well as expiration, provided the obstruction is fixed. So just inspire against a obstruction and expire against an obstruction. So both the volumes are going to decrease, like inspiratory curve as well as expiratory curve. Then comes, if the obstruction is variable, what to do? So in case if you have a variable intrathoracic obstruction, as in a tracheomalacia at the distal level, or a polychondritis, or a tumor of a mainstem bronchi, which is like mobile or so. So what happens in case of an intrathoracic obstruction? The obstruction is inside the chest. What happens when you inspire? There is a negative airway pressure when you inspire. So the inspiration is not going to be a problem because the obstruction is variable. That's all. But when you expire, the airway gets a positive pressure because the pleural pressure from negative value tends to move towards the atmospheric pressure. So from compared to inspiration, the pleural pressure is quite high during an expiration. That leads to increased intrathoracic pressure. What happens when there is an increased intrathoracic pressure? There is a compression already inside the trachea due to tracheomalacia or so. But when there is a compression from outside, it compresses the airway further. That leads to closage of the airways in the expiratory part of the curve. As you can see, this is inspiration. When the patient is inspiring, it is a negative airway pressure. So this is intrathoracic obstruction, right? So the intrathoracic obstruction is somewhat relieved when there is a negative pressure because the airway tends to open up. Okay. But when there is expiration, it is actually a positive pressure compared to inspiration. So this goes and compresses the airways, which is already compressed. So that leads to flattening of the expiratory part of the curve. In other words, intrathoracic compression leads to flattening of expiration. Okay, clear? Next, variable extrathoracic obstruction. In this case, the obstruction is extrathoracic. Whatever positive pressure you develop within the lungs, it is not going to obstruct the flow in the expiration because the obstruction is not inside the thorax and is not going to affect the expiration. So the expiration is not going to be a problem because it is outside the thorax. But when you inspire forcefully, there is a negative transmural pressure already. this negative transmural pressure sucks in, and this causes the airway to collapse during an inspiration. So the inspiratory part of the curve is kind of curved in case of a variable extrathoracic obstruction, which occurs in a case of chronic neuromuscular disorders or an obstructive sleep apnea or vocal cord palsy, where it is variable. This tends to occur because of the negative transmural pressure, which is transmitted across the airways. It tends to collapse the airway during the inspiration. In extrathoracic obstruction, the inspiration is flattened. In intrathoracic obstruction, the expiratory part of the curve is flattened. So then comes another parameter, which is the reversibility with the bronchodilator. So in case you have an obstructive disorder and the flow volume loop is inspiration will be normal and the expiration will be somewhere kind of curved and have a dog-like appearance, signifying it as a severe obstructive disorder. You give the patient albuterol 2.5 milligrams nebulization and repeat the PFT after 20 minutes. If the patient is having an asthma or a reversible exercise-induced bronchoconstriction and so on, then the patient may have actually a bronchodilator response and the FEV1 will actually increase by more than 12% and the FEC or FEV1 will actually change more than 200 ml. So as you can see, the curve from the curved part or the concave part has actually been to a significant improvement, I would say. Now compare this. So this is the pre-treatment asthmatic patient signifying a severe obstruction. Here you can see the graph. After treatment with the bronchodilator, there is a significant increase in the peak expiratory flow rate, and also the downward going has actually significantly decreased to such as a normal curve. So this suggests there is reversibility with the bronchodilator, and you can go and treat the patient with the bronchodilator for the particular event. So reversibility means the patient should have more than 12% change in FEV1 and more than 200 ml change in FEV1. Both should be there for confirming the reversibility. So as of now, we have seen bedside pulmonary test, lung mechanics, static lung volumes and capacities. In dynamic, we have seen volume time loop, maximum breathing capacity. Then we have seen flow volume loop, PEFR, maximum mid expiratory flow rate, and flow volume loop assessment. In the dynamic test, next we have come for the pressure volume loop. Okay. In this pressure volume loop, actually it's an this graph is more kind of an arbitrary one, which has grown significant impact after the development of ARDS. In here, the pressure is put in the x-axis and volume is put in the y-axis. As you know, there is a negative inspiratory pressure, so the patient inspires until the patient has a zero airway pressure, then the patient expires to a positive airway pressure until it becomes zero. So this is a normal patient whom it is like an extrapolated one from the alveolar trace. So it's not like it's a perfect one, but it's an extrapolated one. So when the pressure is zero, it actually kind of moves from the zero baseline. But when you apply some pressure to the patient, say you put the patient on CPAP for obstructive sleep apnea, what happens is you are giving some positive end expiratory pressure. Then the curve, what happens is nothing happened to the curve except that the curve moves towards the right because you have increased the pressure from there and helps the patient to inspire and expire normally. In case, this is actually taken in case of this is a pressure volume loop of a volume control patient where the flow is constant, only the volume will vary dependent. I mean, the volume also is mandatory. This is a pressure volume loop, pressure in the x-axis and volume in the y-axis. Why have they made this is to find out what optimal PP will give to the patient. In this curve, this is the inspiratory part of the curve and this is the expiratory part of the curve. In here, as in this graph, you have applied PEEP to the baseline, so the pressure has shifted to the right. If you have not applied baseline, then the curve would have started somewhere from here. Okay, so you have applied some PEEP, so the graph has started from here. And this is the lower inflection point. This is the minimal pressure you need to apply for the alveoli to recruit altogether. So that is the minimum pressure required to alveolar recruitment is the alveolar lower inflection point. So this is the lowest pressure which you can overcome the airway resistance. That reflects the lower inflection point. Above this lower inflection point, all the alveoli are recruited at once and the compliance increases and reaches to a plateau point. So this is the level of optimal compliance. What is compliance? Change in volume for change in pressure. So you have given, say, 1 centimeter pressure, the volume has increased. Say you've given 2 centimeter pressure, again the volume has increased. But here you say you have given so much amount of pressure, but then the volume has not increased drastically, which means the alveoli are not open yet. Only here the alveoli has opened, leading on to change in the volume when the pressure is applied. So this is beaking or over distension. This is the peak airway pressure. Here is the pressure. It is the peak airway pressure. That is the maximum pressure which is attained at the tidal volume. So look here, there is actually, you are increasing the pressure, but then the volume is not increasing, which means all the alveoli are already recruited. How much ever you pressure you apply at this point of level, the tidal volume is not going to change. So there is no use in applying more pressure than what you have already applied, and all of it is going to be wasted, or it is going to cause a barotrauma and over distension and alveolar rupture. So this is the alveolar distension point, and here comes the upper inflection point. This upper inflection point is a point in the expiratory part of the curve at which the alveoli are maximally distended, and from here the re-recruitment occurs or the expiration occurs. From this part of the curve, we can actually calculate the work of the breathing and the dynamic compliance as well. Then comes the fourth parameter of dynamic test, which is the respiratory muscle strength. All dynamic tests need a good muscle power. Suppose, say, if my muscle power is weak, then I'm going to inspire like if my muscle power is good, then I'm going to inspire like so negative pressure or positive pressure which is generated during inspiration and expiration respectively is measured using an aneroid gauge meter, and the normal peak inspiratory pressure is minus 125 centimeters and the expiratory pressure is somewhere around 200 centimeters. And if the PI max is going to be less than 25 centimeters of water, there is going to be inability to take a deep breath. So whenever you say, we'll always learn in theory, right? When the peak negative inspiratory airway pressure is minus 20 to minus 30 centimeters, then you can reverse the patient. So that is the peak pressure which we are talking about, so that the muscle power is adequate. And the peak expiratory pressure is somewhere around 40 centimeters of water. If it is going to be less, then the patient is not going to cough and you are going to land up in postoperative pulmonary complications. So this is the graph which shows the positive expiratory pressure at the expiration, which is somewhere around 160, and the negative pressure which is developed during inspiration, which is somewhere close to 120. And this is the aneroid gauge meter, which is used to measure the breathing, airway pressure. So as of now, we have finished lung mechanics, dynamic test, and the static and the dynamic test. Now we have come for the test of gas exchange, which is a parenchymal function. Then we have a cardiopulmonary interaction. So why we have to test gas exchange is that there is a function of the lung parenchyma. You are inspiring deeply, you are expiring deeply, but when the parenchyma is damaged, then there is going to be a no gas exchange and the patient is not going to take in oxygen or bring out carbon dioxide. So you need to know whether the lung parenchymal function is normal. How do you do it? You do a plain ABG. You see the alveolar, we have seen in the previous class, the alveolar oxygen minus the arterial oxygen. If the diffusion across the membrane is going to be all right, then the value is going to be all right. It also, the ABG also reflects the ventilatory property of the lungs, which is the carbon dioxide, and also the biochemical properties like determining the pH and also the metabolic component, which is going to be the bicarb. Then comes the diffusion capacity of carbon monoxide. So diffusion capacity of carbon monoxide is also called a transfer factor of the lung. It measures the diffusion across the alveolar capillaries and the alveolar membrane. And here you use a test gas, you give a test gas to the patient, ask them to inspire and expire the test gas through a single breath to a residual volume, and then inspire total to a total lung capacity, hold it for 10 seconds and then expire. You see the concentration of carbon monoxide which the patient has inspired and the patient has expired, and then you determine the diffusion capacity across the lung capillaries. What is the test gas used? It is the 10% helium with 0.3% carbon monoxide with 21% oxygen as normal, and the remaining is nitrogen. So whatever diffusion capacity is directly proportional to rate at which it is diffusing divided by the driving pressure. So the rate at which the carbon monoxide is diffusing is given by ml per minute per millimeter. The driving pressure is the driving pressure across the pulmonary alveoli to the pulmonary capillary of carbon monoxide. Normal is somewhere around 20 to 30 ml per minute per millimeter of mercury. And in this, also we have a percentage predictor. If it is more than 80, then it is going to be normal, and so on, as in case of a previous FEV1 and FEC which we have seen. So in this, the notorious question comes, why are we using carbon monoxide? Because carbon monoxide has got a 200% more affinity to hemoglobin than oxygen. It is easy to have a easy affinity and easy transfer across the alveolar capillaries. And mostly we assume we do not inhale carbon monoxide normally, right? So normal concentration is actually 0. Then you can actually extrapolate. Suppose if we are actually having normally carbon monoxide, then it will become difficult for us to estimate the value of carbon monoxide which is present in the body and then equate it to. So we assume that the normal concentration at the pulmonary circulation is 0, then it becomes easy for us to measure across the diffusion across the membrane which is going to happen. So what are the factors which affect the DLCO or the transfer factor is, this is the airway, alveoli, the pulmonary artery and the pulmonary vein. So in this alveolar, there is a alveolar membrane against which the carbon monoxide must travel. Suppose if the alveolar capillary membrane is fibrosed, or there is a fluid between the alveolar capillary membranes, like in pulmonary edema, then the DLCO will become decreased. Or when there is no perfusion across it, when there is a pulmonary embolism, there is no blood supply at all to this segment. So it is going to become a V by Q segment and it is not going to diffuse. Then again, the DLCO is going to decrease. When there is lesser hemoglobin in the blood, as in case of anemia, again the DLCO is going to be less than 80% predicted. When there is a damage in the airways, so that there is no distributing alveolar sacs in the lower area, as in case of COPD in emphysema, then again you are going to land up in a decreased diffusion capacity. When this capacity will get increased, anemia is going to decrease, so polycythemia is going to increase the DLCO. In case the patient is doing an exercise, there is going to be an increased flow across the lungs and DLCO is going to increase. In case of an early congestive cardiac failure, when the demand is more, then the DLCO is going to be more. So as of now, we have finished the test for lung mechanics and the gas exchange. Now we are going on to the cardiopulmonary reserve. In cardiopulmonary reserve, at rest, the oxygen consumption is somewhere around 250 liters ml per minute, and VO2 is 20 ml per kg per minute. And the stair climbing test, when you climb, this is the first test which we are going to see. One flight of stairs, which is 20 stairs, which is 6 inches height, and the patient is going to walk at their own pace. When there is less than one flight climbed, then the VO2 max is less than 10 ml. And when there is 2 flight climbed, VO2 max is somewhere close to 12 ml. And 5 flight climb, it's 20 ml. And then 6-minute walk test. If the patient is going to walk less than 600 meters, then the VO2 max is going to be less than 15 ml per kg per minute. This I have put because the maximum VO2 max is for a cyclist who is Lance Armstrong, which will be given in Miller, and please go through it. And shuttle walk test, you keep two shuttles at a distance of 10 meters. And if the patient is going to walk somewhere close to 350 meters, then the patient is having a VO2 max of around 11 ml per kg per minute. So in a cardiopulmonary exercise testing is another cardiopulmonary interaction test in which we will measure about anaerobic threshold, maximum oxygen utilization, ventilatory equivalent of oxygen, carbon dioxide, and the peak heart rate. So split lung test, I'm not going to go in detail. This is not done as routine practice. This is actually done in case of a postoperative to determine how the postoperative lung function is going to be. And if 2 lobes are removed or more than 9 segments are going to be removed in a bilateral lung disease patient. So it includes lateral position test wherein the spirometry itself is done in the lateral position. So it can predict response to a lateral position, but under anesthesia response is not guaranteed. Bronchospirometry, it involves giving a DLT in an anesthetized patient and seeing if the patient is going to improve using a radioactive oxygen uptake. And radiospirometric VQ scan, which involves xenon for ventilation scan and iodine for perfusion scan, seeing the regional ventilation and perfusion. And temporary pulmonary artery occlusion is done for pneumonectomies where FPV1 is less than 800 ml, and the normal increase can be 5 millimeters per minute. And if the pulmonary artery pressure is going to be more than 35 and there is going to be retention of carbon dioxide with the significant hypoxemia, then it is going to be a contraindication for the surgery. And selective bronchial occlusion test we can detect using a fibro-optic bronchoscope. A balloon-tipped catheter can be kept, and that can be used to determine if the patient is going to tolerate the lung volumes now. So how are we now? When we started, we were like sincerely listening, and now we are like, oh my God, this is what my Anbu does. He's with it. So whenever he is given some activity, he just jumps out and finds his own way and reaches there. So just to refresh, I've given a few examples of interpretation of spirometry. As in case of obstructive disorder, this is just a revise of all the things which we have seen. So in an obstructive pattern, the vital capacity is going to be normal or decreased, and total lung capacity is going to be normal or increased. And the residual volume is going to be increased. FEV1 by FEC, because of fall in FEV1, it is going to be decreased, and the maximum mid-expiratory flow rate is going to be decreased, and maximum breathing capacity is going to be decreased. In restrictive pattern, all lung volumes and capacities are going to be decreased except for the mid-expiratory flow rate because of the concomitant fall in the other factors. So in the interpretation of spirometry, you have to assess the validity, determine the ventilatory pattern, grade the severity, and grade the response to the bronchodilator. So in case of a pulmonary function test, how do we interpret? This forms the basis algorithm. So pulmonary function test. First of all, you see the FEV1 by FVC. If at all, more than, this is lower limit of normal, which is actually 80% or 70% or 0.7. If the FEV1 by FVC is normal, say yes, then you see the FVC. If the FVC is again normal, it means every other parameters are normal. Then you see the diffusion capacity. Even if the diffusion capacity itself is normal, then it is going to be a normal pulmonary function test. But every lung volume and capacity is normal, but then the diffusion alone is not normal, then it means DLCO is less. It means carboxyhemoglobinemia or anemia. So this part of the graph is done. If the FVC is not normal, FEV1 by FVC is normal, but FVC is reduced, it means then you see the total lung capacity. If the total lung capacity is reduced and FVC is reduced, then it means the patient probably has a restriction. Restriction can be from a chest wall disorder or from an interstitial disorder. So then you see the DLCO. In chest wall disorder, there is no parenchymal etiology, so the DLCO will be normal. Again, in an interstitial lung disease, the membrane is affected, hence the DLCO will be less than predicted. This part of the graph is done. Then FE1 by FVC, it is less than predicted, and you see the FVC. If the FVC is normal, so FEV1 by FVC is less and FVC is normal, then it means an obstructive pattern. In any obstructive pattern, you see DLCO. If the diffusion capacity is normal, it means it's an asthma or non-emphysematous one. If the diffusion capacity itself is limited, then it means an emphysematous one. Here, in case of a mixed disorder, the FEV1 by FVC will not be normal, will be less as in case of an obstructive disorder, but FVC also will be less. Then coming on to total capacity, total lung capacity, even that is decreased, then it means a mixed defect. I hope I'm clear with this. So here are the few exercises which we would see. In this case, where the patient is admitted for an elective surgery, here, first of all, see the FEV1 by FVC. I'll finish off in 10 minutes. I'm sorry for being late. FEV1 by FVC, see 75 by 95. It is close to somewhere close to 0.8. Then you go and see the total lung capacity. The total lung capacity also seems to be more than 80% of predicted. So altogether, FEV1 by FVC is normal, total lung capacity is normal, then it means it is a normal PFT, provided they have not given the DLCO. Coming on to this PFT, you see FEV1, it is 75, and then FVC is 60%. So FEV1 by FVC, you actually put, then it will become more than, it is close to normal. But you see the total lung capacity, it is actually less than 80% predicted. So the total lung capacity is less. It means that the patient has got a restrictive disorder. FEV1 by FVC is normal, but the total lung capacity is decreased. See the residual volume. Residual volume also is decreased. So this means it's a restrictive disorder. It's very easy to interpret a PFT. So a few more examples. See the FEV1 by FVC ratio. It is actually, FEV1 is 12. So from this itself, we can tell it's a very severe obstructive disorder. FEV1 is less than 10%, less than 20% predicted. So it's a very severe obstructive disorder. So it's an obstructive disorder. Here comes another example. See, FEV1 is 68% of, so this is a reference. It is 65% of predicted. I think everybody can say it, 65% of predicted, and this is 78% of predicted. So FEV1 by FVC is close to normal. See the total lung capacity, it is somewhat decreased. See the total lung capacity, it's somewhat decreased. See the DLCO, also the predicted percentage is decreased. So there is a restriction with the diffusion effect. So that is it. And this is an example for a bronchodilator reversibility. See the FEV1 here, pre-bronchodilator it is 74%, and the post-bronchodilator is 82%, and the increase is somewhere close to around 1.33 liters to 1.89 liters. And coming on to the last part of the session, which is the preoperative assessment for lung resection. Why should we actually stratify is to see which patients will go for any postoperative pulmonary complications, who are the high risk patients, who will need postoperative elective ventilation, and so on. Any patient's preoperative assessment will look for history, comorbid illness, lab investigations, and the pulmonary function test. So as far we have seen, the single most important predictor for postoperative pulmonary complication is the predicted postoperative FEV1, which is preoperative FEV1 into 1 minus functional tissue removed divided by 100. So in this example, so the right lung has 3 segments, 6, 4, and 12, and the left lung has 2 segments, 10 by 10. Say, for example, if the predicted preoperative FEV1 is 80%, say you are going to remove the left upper lobe. So total lung segments is 42. So you are going to remove 10 by 42 is 0.25%. So 25% of the lung you are going to remove. So according to the formula, it is 80 into, according to the formula, it is preoperative FEV1, which is 80 into 1 minus functional tissue removed divided by 100. So 1 minus 25 by 100, which becomes it as 60%. So if the predicted postoperative FEV1 is more than 40%, then you can actually plan the surgery without any further complications and extubate the patient on table. This is from 8th Miller. So if the predicted postoperative FEV1 is 30 to 40%, then you can consider other factors like diffusion capacity, exercise tolerance, and then decide about extubating the patient on table. If the predicted postoperative FEV1 is less than 30%, then you consider mechanical ventilation and then decide upon. As we have seen previously, this is a 3-legged stool for the pre-thoracotomy assessment, which includes respiratory mechanics, cardiopulmonary reserve, and the pulmonary function, which we have seen it earlier. So this is from 9th edition Miller. In the preoperative risk stratification, you see the functional capacity and the predicted postoperative FEV1. If it is more than 60, then there is no issue. You can go ahead with the surgery. But then when it is 30 to 60%, you do a simple exercise testing. If the 6-minute walk test, if the patient is able to walk more than 400 meters, then you proceed with the surgery. If the patient is able to walk only less than 400 meters, then you go for cardiopulmonary testing. Cardiopulmonary testing, if the VO2 max is more than 10 ml per kg per minute, then you have an increased risk. Also, if it is less than 10 ml, you actually defer the patient for then surgery and then treat them with the medical optimization. If the spirometry is showing a decreased postoperative FEV1, then again you go for the cardiopulmonary exercise testing. Depending upon the VO2 max, you either defer them or accept them under high risk. In British Thoracic Society has used only the predicted preoperative FEV1. If it is 1.5 liters, then the patient can be fit for lobectomy. And preoperative FEV1, it is more than 2 liters, then the patient is fit for pneumonectomy, is what BTS gave us in 2011. But American College of Physicians gave like, you see the predicted postoperative FEV1 and then decide the outcomes. Routine cardiac evaluation is needed for all the patients to rule out pulmonary hypertension as well. And the predictors of morbidity and mortality are the postoperative FEV1 or DLCO less than 40, inability to walk less than 250 meters in a 6-minute walk test on 2 occasions, when the VO2 max is less than 10 ml per kg per minute, and the predicted preoperative DLCO is less than 60, and the VO2 max of 15 forms the borderline between the medium and the high risk patients. So to summarize, PFT has a bedside test which includes the match blowing and all that, and lung mechanics, parenchymal function, and cardiopulmonary reserve. It is used in preoperative risk stratification and decision making for lung resection surgery, and to determine whether there is an obstructive disorder or a restrictive disorder. And cardiopulmonary exercise testing is a non-invasive method to predict the outcomes of the patient presenting us for a lung disease. Thank you.
Thank you, Dr. Guru Santhiya. That was a very crystal clear explanation that the chat box is full of compliments rather than doubts. I just have one doubt to be cleared. A student have asked, in Sabri's breath count test, who should count the numbers?
The patient themselves.
Thank you. So I think we can move to the next session. Thank you, Dr. Guru Santhiya.
Thank you.
Thank you. So now we have a video presentation on Fascia Iliaca Compartment Block, landmark technique by none other than our eminent speaker, Dr.Kala Eswaran ma'am. She is a senior consultant anesthesiologist in Mumbai. She has credits of national and international publications. She has also received various awards for variety of presentation and conferences. She also authorized a book on nerve blocks. She has conducted her own difficult airway workshops and nerve block workshops. Over to you, Dr. Kala Eswaran ma'am.
Hi friends, today I'll be speaking on Fascia Iliaca Compartment Block. The images which I have taken are from Nicera internet, and I have obtained the patient consent. No disclosures. Now, coming to the innervation of the lower limb, as you can see, the lower extremity innervation is provided through 4 major nerves. That is the sciatic nerve posteriorly, the femoral nerve, the obturator nerve, and the lateral cutaneous nerve of the thigh. The femoral nerve, the obturator nerve, and the lateral cutaneous femoral nerve all arises from the lumbar plexus. Sciatic nerve originates from the lumbar as well as the sacral plexus. Hence, it's called lumbosacral plexus. Now, if you see the innervation in terms of dermatomes, myotomes, and osteotomes, the major nerves anteriorly is your femoral. It's the largest branch of the lumbar plexus. Okay, and after supplying the skin, anteromedial surface of the thigh and the medial aspect of the lower limb, ankle and foot in its terminal branch, that is the saphenous nerve. The obturator nerve is motor to the hip adductors, okay, and sensory to the skin just above the knee joint medially. And for the osteotomes, if you see, the majority anteriorly is by the femoral, and the hip and the knee by the obturator, and posteriorly by the sciatic. The major muscles is supplied by the femoral, okay, and the hip adductors by the obturator. If you see, the femoral is the largest branch of the lumbar plexus, originating from the posterior divisions of anterior rami L2, 3, 4, descends through the posterior 1/3 of the psoas major muscle, emerging from its lateral border and continues caudally between the bulk of the psoas major and the iliacus muscle here, enters the thigh behind the inguinal ligament lying lateral to the femoral artery and on top of the iliacus muscle, separated from the artery medially by the fascia iliaca. Okay. The obturator nerve originates from the anterior divisions of the L2, 3, and 4 rami, descends with the psoas major muscle, emerges at its medial border behind the common iliac vessels, lateral to the internal iliac vessel, and enters the thigh through the obturator foramen here and divides into the anterior and the posterior branches. Then comes the lateral cutaneous nerve. Okay, it arises from L2 and 3, emerges from the lateral border of the psoas major muscle, runs on the ventral surface of the iliacus muscle, heads towards the anterior superior iliac spine, okay, behind the inguinal ligament. At its insertion to the anterior superior iliac spine, it emerges outside and divides into two branches, anterior and posterior branches at this junction. Okay. Now, fascia iliaca, what are the approaches to the femoral nerve? So you can approach, if you see the course of the femoral nerve, you can approach it supra-inguinal, superior to the inguinal ligament, that is the supra-inguinal approach, inferior to the inguinal ligament, that is the infra-inguinal approach to the fascia iliaca compartment block, then the classical traditional femoral nerve beyond the inguinal crease, and after it supplies the motor branches where it lies at the adductor canal and then continues forward as the saphenous nerve. At the adductor canal, you can block the femoral nerve, that is the saphenous nerve. The fascia iliaca compartment is also known as the anterior approach to the lumbar plexus. The fascia iliaca compartment is a potential space lying between the fascia iliaca anteriorly, the iliacus and the psoas, the iliacus and the psoas muscles posteriorly. The fascia iliaca attaches to the iliac crest here laterally and to the fascia overlying the psoas muscle, okay, medially. Posteriorly to the external iliac vessels and anteriorly to the lumbar plexus. Okay. Distally, it invests the femoral nerve and passes posteriorly to the femoral artery and vein, the vessels which lies in the lacuna vasorum. Here is a cadaveric picture where you can see the iliacus muscle. This is the fascia iliaca compartment, suprainguinal compartment and infrainguinal compartment. Okay, showing the boundaries very nicely here. You can see that the fascia iliaca going over the femoral vessels. Okay, and this is the femoral nerve. Okay, which is further away from the vessels suprainguinally. Okay, whereas infrainguinally you can see how the nerve runs along the vessels. Now, after knowing the boundaries, you can see that the fascia iliaca, this is a pictorial representation showing the fascia iliaca compartment and the three nerves, that is the lateral femoral cutaneous nerve, the femoral nerve, and the obturator nerves here. They are in a continuous compartment, but you can see the difference that the obturator nerves are separated from the femoral and the lateral femoral cutaneous nerve by the psoas major and the pectineus muscle. And hence, though placement of LA drug in the fascia iliaca compartment can block all the three nerves, the obturator nerve, because it's far away from these two, it may not be always blocked in the fascia iliaca compartment block. Also, you can notice that in the compartment also lies the genitofemoral nerve. So genitofemoral, which runs in the anterior aspect of the psoas muscle, posterior to the fascia iliaca, mostly gets blocked in the fascia iliaca compartment block. Coming to the history, Venni et al. In 1973 showed us a landmark guided 3-in-1 block for the first time. Dellens et al. In 1989 showed us a landmark guided infrainguinal fascia iliaca compartment block, that is a classical approach. Dellens et al. In 2006 showed us the USG guided fascia iliaca compartment block. Stevens et al. In 2007 showed us a landmark guided suprainguinal fascia iliaca compartment block, and Hebard et al. Showed the same using USG in 2011. What are the indications? Any sort of fracture femur, fracture neck of femur especially, in the perioperative or postoperative analgesia, or even if you increase the concentration of the drug, you can give anesthesia too. Therefore, it can be used at the accident site while transportation or as an on-arrival block for pain relief. It can also be used to give pain relief so as the patient can give position for your spinal or epidural. Minor surgeries in the extensor compartment of the thigh, adjuvant anesthesia for about knee amputation, knee surgery in conjunction with sciatic nerve block, it can give a complete anesthesia too. Contraindications is the patient refusal, infection or inflammation in the region of the block, that is the groin, allergy to local anesthetic agents, certain skin conditions in the groin, septic arthritis of the hip joint, or previous femoral bypass surgeries, that is femoral vessel bypass surgeries, it is contraindicated. Advantages: it gives excellent, good compartment nerve block from hip to knee. Significant reduction in the requirement of morphine was noticed. Reduced rates of deep vein thrombosis because of early mobilization postoperatively. And the block also reduced the delirium and cognition impairment because of excellent pain relief, especially in the elderly with fractured hip. It is extremely low-skilled, inexpensive, and effective technique, just the right attitude to give the block is needed. Landmarks. Here the landmark is bony landmark is the pubic tubercle and the anterior superior iliac spine. These are the two landmarks which even in the obese patients you can feel it very nicely. Draw a line from the pubic tubercle to the anterior superior iliac spine, that is the inguinal ligament, and around 2 centimeters below lies your inguinal crease. Now divide the inguinal ligament into 3 equal parts. Okay. Now where is your point of needle entry is? That is at the lateral 1/3 and medial 2/3 junction of the inguinal ligament. Just few millimeters or 1 centimeters beneath that lies your point of needle insertion. You can keep your 2 fingers, make 2 V, okay, with both the hands. Keep 1 finger at the anterior superior iliac spine and 1 at the pubic tubercle. You get equal 3 parts, okay, and lateral 1/3 and medial 2/3, just beneath that, above the inguinal crease, is your point of needle insertion. At this level, you are very much far away from the femoral artery and vein. Okay, so you are very safe. You can always palpate and check whether you are far away or not. What are the equipments? Sterile gloves, sterile gauzes, povidone iodine or chlorhexidine for skin preparation, 2% xylocaine plain for local infiltration, because you are going to use blunt needles. It will be very painful, therefore better to give local. You can either use bupivacaine or ropivacaine, 20 cc syringe, and the hypodermic needle, that is 21 gauge hypodermic needle, 1.5 inch of length, which comes along with the 20 cc syringe, is easy to use. You can also use the Stimuplex needle, 5 centimeters, which comes along with an injection port, and blunt tipped 22 gauge. Technique. It is good to use, explain the, good to take consent, explain the procedure well to the patient. Do it under all aseptic precautions. Assistant is mostly needed when you are using an injection port, so that you can keep the needle and the assistant will inject the LA drug. And also when the patient is obese with pendulous abdomen, the assistant can retract the abdomen away from the side for you. Patient is in supine position with legs slightly abducted. 21 gauge hypodermic needle can be used. Also, Stimuplex or epidural needle can be used. The fascia lata and fascia iliaca forms the basis of this block. Hence, you have to remember is bounce, pop, bounce, pop. That is 2 bounces and 2 pops. The first bounce and pop is of the fascia lata. As the needle goes beneath the skin, the subcutaneous tissue, you get the first pop, that is of the fascia lata, and then you get the second bounce and pop, that is of the fascia iliaca, when you further advance the needle to enter the fascia iliaca compartment space. Now I'll show, keeping this in mind, I will show the video. You can see that the pubic tubercle and the anterior superior iliac spine is marked. At the point of needle entry, see, again I'm assuring, go bang perpendicular after giving the local. This is a blunt 22 gauge Stimuplex needle. You see the bounce and the pop. That is the first bounce and pop of fascia lata. This is the second bounce, second pop. That is the fascia iliaca, and aspirate and inject into the fascia iliaca compartment space to get a good fascia iliaca compartment block. Now, when you want to use a hypodermic needle, you have to blunt the tip. So you can do that via tapping the needle tip on the sterile surface. This is the straight needle. This is the needle after blunting it. You can see that the tip looks like a parrot beak here. This is a video showing how I'll be using 21 gauge hypodermic needle that comes along with 20 cc syringes, or you can get a 1.5 inch needle, tapping on the sterile surface. Once or twice is enough. Now the needle tip is blunted or bent, but the sides of the needle is still sharp. Feeling for the anterior superior iliac spine and the pubic tubercle. Make 2 V. You can see the inguinal ligament line and the inguinal crease here very nicely. Now, see very nicely, the inguinal ligament is divided into 3 parts, and at the junction of the lateral 1/3 and medial 2/3 is your needle entry point. Now the blunted needle is used. Remember, the tip is blunt, so it won't enter. So how will you enter is through the sharp edges at 45 to 30 degrees. You pierce the skin, enter, and then you make it perpendicular. That is your first bounce. Go further. You'll get the first pop, that is the fascia lata is pierced. Then you got the second bounce and second pop, that is the fascia iliaca is pierced. Now you take the LA drug, hold the needle carefully, aspirate and inject. After every 5 cc, aspirate and look for free flow of drug coming back through the needle. See, you can see the free flow. That means you're not in the iliacus muscle and you are in the compartment. If you're in the iliacus muscle, you need to withdraw the needle a little bit outside. You can see the free flow of the. Now, total 30 to 40 ml of LA drug has been given after repeated aspiration. And checking for free backward flow of the drug. Okay. The remaining of the drug is injected. Now coming to what is the effective volume to get an effective block. Okay. It has been described as the volume which will give good block of all the 3 nerves lying in the fascia iliaca compartment. In the classical fascia iliaca compartment block, the volume was described as 30 to 40 ml. So many studies have been done and they have found that the effective volume to block 50% good block is around 28.79 ml for ropivacaine and 29.5 ml for bupivacaine. To get 95% effective block, it was around 34 ml for ropivacaine and 36 ml for bupivacaine. And to get 99% block, that is 36.6 and 37.3 ml for bupivacaine. Hence, it was seen that the good effective block volume, the average dose is around 36 to 37 ml. That means as you increase the volume, the efficacy of the block is also increased. Okay. And in the suprainguinal approach, that is when you enter the fascia iliaca compartment block above the inguinal ligament, they have seen more cephalic spread, more effective block with lesser volume. So minimum to get 50% effective block was around, minimal volume was around 15 ml, and to get 95% block, the volume was around 27 ml. You have to keep this in mind. To get effective volume, you need around, even this averages around 30 ml. So it will be nice if you can give around 30 to 40 ml. Limitations include inguinal innervation. You have to understand the area around the anterior superior iliac spine is supplied by the subcostal nerve. Sometimes for a fractured femur, they need to do a percutaneous nailing and they go higher up. So it is not the block which is inadequate. The innervation is by the subcostal nerve. Therefore, you need some local infiltration around this area. Also, in the just at the groin, the innervation is by the ilioinguinal nerve and the genital branch and the genitofemoral branches here. So you need to block them separately. Especially this is seen when you have some skin conditions or skin infections, debridement, skin grafting, or some abscess or some lesions, inguinal node and all. So you have to remember that this needs to be blocked separately. Coming to the last slide, that's the pearls. Find the landmarks carefully. They are the anterior superior iliac spine and the pubic tubercle. The fascia lata and the fascia iliaca are the two most important thing which forms the basis of the fascia iliaca compartment block. Hence, you have to feel for the bounce pop of as the needle pierces through the fascia lata and the fascia iliaca. If there is any resistance during the administration of the LA agent, or if there is no backflow of the drug, slowly pull the needle a little bit outside and try administrating the LA agent again. You might be into, the needle tip might be in the fascia iliaca muscle. This is a volume dependent block. Say for large volumes are required to achieve good analgesia, usually around 30 to 50 ml. Therefore, you have to calculate the drug concentration and dosage as per the patient's weight. You can add additives like Dexa. 8 milligram Dexa is far superior to 4 milligram. You can easily use 8 milligram Dexa for long acting. You can achieve around 36 to 48 hours of good analgesia. Clonion can be added, dexmedetomidine can be added, and even Maxilf has been added by many. But addition of one single adjuvant is enough to get good prolonged analgesia. The placement of manual pressure inferior to the injection site can be done so that the local anesthetic agent can flow cranially. Okay. In all, fascia iliaca compartment block is a volume dependent block, very easy, just a needle and syringe filled with LA is required. So I hope I have explained well. Thank you. Thank you all.
Sure, ma'am. Thank you. We'll move on to the next topic. It is the most important topic, lung isolation techniques and its challenges, by Dr. Sathish Kumar, sir. He's a professor in Cardiothoracic Anesthesiology, CMC Vellore. He has made over 16 publications in different fields like cardiothoracic anesthesia, pediatric anesthesia, arrhythmias and obstetric emergencies, etc. And he has won many awards in various conferences. Over to you, sir.
Good morning. Am I audible?
Yes, sir. You're audible, sir.
Yeah. Okay. First of all, I would like to thank the organizer for giving me an opportunity to present in this wonderful CME program. I'll share my presentation. I'm Dr. Sathish from CMC Vellore. Greetings from CMC. Today we are going to discuss about lung isolation techniques and how we are going to isolate with various devices. What is the indication for one lung ventilation? Protection of healthy lung from infected material or blood or fluid, such as bronchiectasis or lung abscess or any pulmonary hemorrhage. Or the next one is diversion of ventilation from damaged artery or lung. It is like bronchopleural fistula, bronchopleural cutaneous fistula, or any other air leaks. And Next important thing is improved exposure of surgical field, like video-assisted thoracoscopic procedures or minimally invasive cardiac surgeries where you need to deflate your lung, whichever side the surgeon is operating. We have various options, and the first and foremost is the double lumen endotracheal tube, which is a gold standard. Other options are bronchial blocker and endobronchial tube. What is a DLT? DLT is two tubes bounded together with an oropharyngeal curve and a bronchial curve with two cuffs and two balloons for each cuff. One is called tracheal limb, another one is called bronchial limb. These curves are very useful to facilitate the intubation into the endobronchial area. Now, how will you differentiate right-sided from the left side? It's very important, and we all know right-sided lung as a right upper lobe which takes off very early. So you need a separate slot to ventilate, otherwise you will collapse that part. So whenever you see a DLT, you should see the slot for right upper lobe, and then which is not present in the left-sided DLT, and the cuff of the bronchial lumen also slightly different. In left DLT it is spherical, but in the right DLT it is ellipsoidal. Now comes the important one aspect, the tube selection. Whether you select left or right for that particular patient. The most commonly used tube is left-sided DLT because there is no worry of collapsing right upper lobe or alignment, and it has a better margin of safety. What do you mean by that? Since the right upper lobe takes off early, if you put a right DLT, you cannot move the bronchial lumen in and out too much. So usually it will be less than 2.5 centimeters. You have to place it. But if it is a left DLT, that worry is not there. So up to 5 centimeters in and out you can move. So that is the better margin of safety. This is the reason left DLT is commonly used. But there are certain indications where you have to use right DLT. What are the conditions? First is extrinsic compression of left main bronchus, like tumor or descending thoracic aortic aneurysm or arch of aorta aneurysm, which compresses where you can't force the left bronchial lumen. Or if there is an intrinsic compression, like intraluminal tumor, or if the pulmonary medicine physician places a stent in the left main bronchus for tumor or anything, you can't place the left DLT. Or if the surgeon plans to do a left-sided pneumonectomy or sleeve resection or major transplant, then you have to choose right DLT. This tabular column shows the various sizes of DLT, starts from 26 to 41. It's usually we give a size in French, 26 French to 41 French for DLT. But it is very important to know the diameters of these DLTs. The outer diameter of each size is given, and the bronchial internal diameter and the tracheal internal diameter are also given. Because nowadays it is a standard of practice to confirm the position with fiber optic bronchoscope, and you should know what size bronchoscope you can use when you use a particular size of DLT. Up to 32, 2.2 fiber optic bronchoscope can be used, and more than 32 French, up to 41 French, you can use 3.5 or 4.2 size fiber optic bronchoscope to confirm the position. Yes, you have selected the DLT, but now you need to select the size. This is as a standard, we all know for the female patient, when they're less than 160 centimeter, 35 French, more than 160 is 37. For male, less than 170, 39, and more than 170, 41. But most of our Indian patients are short, less than 150 centimeters. So what size, whether you go for 35, 32, or something else. So the recent classification by Anala et al., they did a CT scan assessment of bronchial diameter. This is mainly for left side, not for right side, because right upper lobe takes off early. It is impossible to do this calculation for right. So whenever you use left DLT for a short patient, most of these patients, when they come for thoracic surgery or any other major surgery like cardiac surgery or sympathetic chain block or video assisted thoracoscopy, they will have a CT scan. So you assess the bronchial lumen bronchial diameter 1 level below the carina. So once if it is less than 10 millimeter, then use 32. If it is 10 millimeter, 35, 11, 37, and 12, 39, and more than 12, 41 French respectively. This is very important because sometimes when you use a very smaller size in a bigger bronchial diameter, the mal position and the tube come into the carina or into the trachea is more common. So you have to use appropriate tube when you select it. This is a video laryngoscope view of insertion of DLT. I hope all of you are seeing this video. You are seeing the glottic structure. The bronchial lumen is going inside the vocal cord. Once it's entered into the vocal cord, remove the stylet, turn the tube up to that 45 to 90 degree towards that particular side. This case, it is left side. So we turn it to left side. If it is the right side, you need to turn slightly into the right side and push it till you feel the resistance. As you all know, we usually clinically examine the correct position by clamping the first tracheal lumen, then bronchial lumen, and auscultate. But the recent studies have proven more than 30% to 40% of the correctly placed DLT by clinical confirmation, when you do a fiber optic bronchoscope, more than 30 to 40% of mal position. So it is very important to confirm it with fiber optic bronchoscope. When you put a left DLT, what are the things you should see? First, you have to pass the fiber optic bronchoscope with the tracheal lumen and see the carina. This is the first picture, carina, where you should see the bronchial cuff just entering into the left side bronchus, main bronchus. Once if it is seen, then you should go inside the right side of the bronchial lumen and see for the right upper lobe trifurcation, which is the landmark for right-sided bronchus. So once if you know this, then you know the bronchial lumen is gone into the left side appropriately. Then take the fiber optic bronchoscope and pass it into the bronchial lumen and confirm whether it is above the secondary level carina. Let us see with this video. You are intubated, you are passing the fiber optic bronchoscope inside the tracheal lumen, and you are going deeper inside. Once if you go and reach near the end of the tube, you should see the tracheal ring above and the trachealis muscle posteriorly, and you see the carina and the bronchial cuff just entering into the left main bronchus. Once if you've seen this, go inside the right main bronchus and confirm whether the right main bronchus is this one, and by seeing the trifurcation of the right upper lobe. Once if you see this, you are very sure that you are not into the right side, your tube has gone mainly to the left side. Then take it out and then go inside the left side and confirm whether it is above the secondary level carina, and make sure that it is above the, otherwise we'll have a higher airway pressure. That's how it has to be confirmed. Next is the right DLT. How are you going to confirm it? Same thing. Once if you place it, you have to pass the first the bronchoscope into the tracheal lumen and see whether it has gone into the right side. And once if it is in the right side, you should pass the fiber optic bronchoscope into the bronchial lumen and see whether it is above the secondary level carina, that is the intermediate bronchus, and then align the right upper lobe towards the align the right upper slot towards the right upper bronchus. Let us see the video. We are going inside the tracheal lumen and confirming that tracheal ring above posteriorly muscle is there. And then once if you go deeper, you can see that tube is gone into the right side. Right? Yes. And you're confirming into going into the left side and seeing the secondary level carina, and there is no right upper lobe. So that is, you are sure that it is right, it is gone into the right side. Then go into the bronchial lumen. once if you go deeper inside, you will see the secondary level bronchus, that is the intermediate bronchus, right lower lobe and right middle lobe. Then pull out the bronchoscope and see the right upper slot in the bronchial lumen, and then align it with the right upper lobe bronchus. You see, now we are aligned and the trifurcation is seen. So this is how right-sided DLT should be confirmed. Even after the patient is positioned in the place in the left lateral or right lateral position, again you need to confirm the position because the tube can slightly move up and down. So you need to realign it with the help of fiber optic bronchoscope. Even though it looks simple, many times you cannot isolate the lung or you cannot place it properly. So what, in case of difficulty, what you can do is keep the DLT, both lumens in the trachea, and pass the fiber optic bronchoscope into the bronchial lumen and take it to the side whichever you want. In this one, it is left side. So you go into the left side and then right roll the DLT into that. So it is very easy. And finally, once if you position, you can bring out the bronchoscope and confirm the position whether it is appropriate. Some people to use a technique where they turn the head to the opposite side, particularly if they want to position the left DLT, they turn the head to the right side, and same thing for the right side, they turn the head to the left side. Next important innovation is the video DLT. Its trade name is Vivaside. It has an integrated camera placed in between the bronchial and tracheal lumen, and it will be continuously, you will visualize what you are doing from the glottic level till up to the carina. And then this not only during intubation, during the procedure or till the end of the procedure, you can visualize whether the tube is in position. It has two parts. One is the tube like any other DLT. Another one is the camera with the USB connection, which will connect to the monitor, and an additional suction port, which will help us to defog, or you can inject some saline when there is a smearing by secretions onto the surface of the camera. Let us see an example. This is a video DLT that we use in our center. So during intubation also, you can visualize the upper airway structure, DLT, the glottic area. See, the tube is going into the trachea. You can visualize the tracheal ring there, and bronchial cuff is very proximal here because the camera is at the level of bifurcation. Then at the level of carina, you see the left DLT is gone, left bronchial cuff is gone inside the left bronchus. So this video DLT is available only in left-sided. There is no right-sided video DLT because it's very difficult to align to the right upper lobe, and it can be used continuously during the procedure. And any malposition, even in the initial stage itself, you can pick it up. So the other complication of malposition like high airway pressure, tight bag, or hypoxia can be prevented. This is a recent paper we published in our Annals of Cardiac Anesthesia. We used this video DLT during the COVID times for thoracic surgery. As you all know, laryngoscopy and intubation itself is a high aerosol procedure. In addition, if you use fiber optic bronchoscope and suctioning, it increases the aerosol production in double or triple times. So we use this video DLT and reduce the aerosol production, and we published. Anybody wants to go through it, this is a reference for that. Next comes the important one, the bronchial blockers. What is bronchial blocker? It is a balloon catheter to occlude the bronchus of the operative lung. When it will be used, when DLT cannot be placed, or if the indication is intermediate or low priority. Well, we have multiple bronchial blockers. They are on blockers, Hooped, Fuji blocker, Univent tube, EZ blocker, and Fogarty embolectomy catheters. There are specific indications for bronchial blockers, particularly when you have a difficult airway, and if particularly when the patient has limited mouth opening, need a fiber optic bronchoscope or nasotracheal intubation, then insertion of DLT will be extremely difficult. So you place a single lumen tube and pass a bronchial blocker and isolate the lung. Or if you have a physiological difficult airway, like a patient coming from ICU with less reserve, you can't extubate and put a DLT, and those time patient may not tolerate. So those conditions, we place a bronchial blocker. Or tracheostomized patients, or in recently they are doing a selective lobar blockade, and they won't collapse the entire, and they collapse only the lobes. Then you can, then with the DLT it is impossible. So they use bronchial blockers. And patients who need post-operative ventilation, like patients with very bad lungs, or when the patient when the patients coming from minimally invasive cardiac surgery where they need post-op ventilation, bronchial blockers can be used as an alternative. This is a univent tube. It is a torque-controlled univent blocker. It can be either intraluminal or extraluminal. Its available sizes are 3.5 to 9. But only disadvantage is it has a high pressure cuff. So it is not used widely because of the high pressure. It causes bronchial mucosal injury, and so many centers are not practicing it. And if you notice, most of the bronchial blockers will have a central lumen from 1.5 to 2 millimeters for collapse of the lung or for suctioning. This also has a 2 millimeter internal lumen and a separate pilot balloon for the cuff. Next important thing is the on blocker. It is called wire guided bronchial blocker. It's available in multiple sizes, 5, 7, and 9, and the length also varies from 65 to 78. The smallest single lumen tube required for size 5 French on blocker is 4.5. But if you use a bigger tube, it is much better because most of these bronchial blockers you will isolate with the use of fiber optic bronchoscope. So to pass the blocker and the fiber optic bronchoscope is always ideal to use a bigger size tube. But here it is high volume, low pressure cuff. So the damage to the bronchial mucosa is very less. And the cuff is a spherical shaped cuff, not the elliptical one. So the damage is also very less. That's what proven in multiple studies. Let us see how it is used. Before that, each blocker, when you use it, you should know the various parts. Most of the blockers will come with a multi-port connector and the blocker itself. In this blocker, if you see, the blocker is, which is a yellow color lumen, yellow color catheter, and it has a wire, flexible nylon wire embedded inside, and it has a external end, it has a connection for it, and it has a pilot balloon to inflate the balloon, pilot catheter for inflate the balloon, and multi-port connector as an endotracheal tube connection, a bronchial blocker insertion port, and a fiber optic bronchoscope insertion port, along with the circuit connection port. So all this port we should know, because appropriately we should connect the system in the respective places. Before you start placing the on blocker, you should do some preparation. This is called coupling of on blocker along with the fiber optic bronchoscope. If you notice here, the bronchial blocker and fiber optics passed in the lumens, and the wire is looped along with the fiber optic bronchoscope above the angled tip of the flexible bronchoscope. Otherwise, the flexion won't work. Once if it is done, then you start inserting inside the endotracheal tube. So, and then connect the breathing circuit, continuously ventilate. You need another additional hand, because when you pass the fiber optic, the other person should slightly help you to push the bronchial blocker coherently. Otherwise, it may not be very feasible to place it. Once if you pass the fiber optic bronchoscope, you can see, you may not see the bronchial blocker because the blocker is wire loop above the flexible tape. You will reach inside the trachea, and then carina is visualized. Go whichever lumen you want to place the blocker. Here it is left-sided bronchus. You enter secondary level carina is seen. Once if you see the secondary level carina, you should loosen the wire loop. See, the assistant is loosening the wire loop. and then he is pushing it. Once if you push, it will decouple and the bronchial blocker will come into the left side bronchus, and you pull out the fiber optic bronchoscope above and keep it above the carina level. See here, the bronchial blocker is too much inside, so you tell the assistant to pull out the bronchial blocker till you see the bronchial cuff. So you could see the blue color cuff just at the entrance of the left main bronchus. Then ask the assistant to inflate the cuff with the air up to 8 to 10 ml, because these are all high volume, low pressure cuff. So the assistant is holding it and inflating the cuff. So once if it is inflated, you can see the cuff is in fully optimal position and it is not protruding into the carina and it is blocking the left main bronchus. So this is how on blocker should be used. After positioning the blocker, it is very important to fix it in that position. Each blocker the multiport connector has a different connections. Here you see there is a twisting mechanism where you tighten it so that the blocker won't move in and out after you place it. This is very important. And after the patient is placed in the left lateral position or right lateral position, again you need to confirm the position with the help of fiber optic bronchoscope, because most of the bronchial blockers are prone for dislodgement. Next is the port duct. It is a torque guided blocker. If you notice, it has a blocker and a multiport connector. Before placing it, it has an angled tip. That is the main mechanism where you can turn it to the right side or the left side. Before positioning, you should confirm the integrity of the blocker. You should inflate and deflate and see the cuff is working. And once if it is done, you can place it onto the endotracheal tube system. Similar like on blocker, one other person is needed to guide with the fiber optic bronchoscope. Once if you pass the fiber optic bronchoscope, you will see the carina and the blocker is pushed. See, if you want to put it in the left side, the angle tip is turned towards the left side. If you want to put it in the right side, the angle tip is turned into the right side and pushed it into the right side. And once if you're sure of the position, you can inflate the balloon. And then take it out. And this scope duct or any other block will have a separate mechanism for fixing it. You have to do it at the after confirming this position. Next is a EZ blocker. As the name suggests, it is a EC blocker, but it comes with a Y limb with two cuffs, not like a single cuff. It has a two cuff. So it will be placed in this second picture. You can see inside the single lumen tube, it is placed like a Y on the carina. So whichever limb you want to inflate, you can use that cuff and inflate it. Before you place the blocker, confirm both the cuff integrity. This is for the yellow lumen and this is for the blue lumen. You confirm the integrity. Once if you're sure about the integrity of the cuffs, you place it inside the patient. See, but while inserting the EZ blocker, make it in such a way that the Y is appropriately placed. If you do it in a diagonal fashion, it may not open up appropriately. Here, what we'll do is we push the blocker little inside rather than railroading along with the fiber optic bronchoscope, because the lumen of the dimension of the bronchial cuff, that the bronchial blocker is slightly bigger. So once if you pass along with the bronchial blocker, it gives a resistance. So usually we push the blocker till we feel slight resistance. Then we pass a fiber optic bronchoscope with some lubrication. This is how the blocker is already pushed inside the endotracheal tube. Then the fiber optic bronchoscope is passed inside the tube, and we go inside. Once if you see the carina, you know the two limbs, both the limbs are gone into the left side. So you bring it out. See, the limb is not opening here because the tube is very close to the carina. Now we pull the tube little bit up, the Y limb is open. This is very important for any blocker. The working space between the carina and the tip of the tube should be at least 2 to 2.5 centimeters. So with fiber optic guidance, we can pull the tube, and so that proper placement of the blocker is very easy. Now the Y limb is placed above the carina, and each cuff is on right and left side. So whichever side you want to block, you can inflate it. So this is much more easier blocker, and this is a blocker we are now commonly using in our center, and very efficiently, and it is working properly. But you need a fiber optic bronchoscope for its positioning. This also has a high volume, low pressure cuff. So 68 ml air should be inflated to appropriately block that particular lumen of the bronchus. This chart shows the comparison between different bronchial blockers. From ESET blocker to Fogarty catheters, you can see the type of the balloon, the guiding mechanism, and the smallest endotracheal tube required for each blocker, and the central channel. The central channel is used for suctioning or for deflation. But as you all know, compared to DLT, it is not easy to deflate so easily with the bronchial blocker. These are the pitfalls of bronchial blockers: slow collapse of the lung, or if there is a difficult to suction because the lumen is very small, you cannot suck it like a DLT. That's why whenever there is a high secretions, pus of blood, it is DLT is the standard of choice, not the bronchial blocker. And since it is very small, more prone for dislodgement. Suppose if the surgeon asks to convert into 2 lung and then again 1 lung, you cannot do it with the bronchial blocker. It is not very easy. And if you push very hardly, it may perforate the bronchus or parenchyma. And since if the right upper lobe takes off very early, it will be very difficult to block with the blockers. And as you all know, it is expensive compared to the DLT. But to efficiently use the bronchial blocker to collapse the lung early, there is a technique. What we have to do is, you should pre-oxygenate the patient till you intubate and isolate, and then once the blocker is placed, don't inflate the bronchial cuff. Before inflating the bronchial cuff, disconnect the breathing circuit. Wait for 15 to 20 seconds. Then now both the lungs will be collapsed. Then inflate the bronchial balloon, and then start the fresh gas flow and ventilate the non-operative lungs, so the operative side will be automatically collapsed faster, and then apply the suction of the bronchial blocker. This is how bronchial blocker can be efficiently used to collapse the lung early. Is bronchial blocker a substitute DLT? No. An absolute indication, as I said, like whole lung lavage, blood, pus, DLT is a method of choice. But as I mentioned earlier, critically ill intubated patient, selective lobar blockade, difficult airway, small patient where DLT sizing is difficult, or robotic surgery for cardiac, thoracic, or esophageal surgeries, bronchial blockers is a substitute to DLT. Thank you very much for your kind listening, patient listening. I'm open for questions.
Thank you very much, sir. And that was indeed a very wonderful lecture with all the live demos with blockers and WMN tubes. For now, we have no doubts in the chat box, sir. So I think we can end with this session. Thank you very much, sir.
Thank you, everybody.
Next week, we'll be continuing on thoracic anesthesia part 2, which involves 1 lung ventilation by Dr. Shivaprasad, sir. So thank you all for your patient listening throughout the session. Thank you very much.